and Vitreous from Aravind Eye Hospital, Coimbatore, and worked in Aravind Eye Hospital, Tirunelveli. I consider this my privilege to introduce him as he is my batchmate at Calicut, as well as we are working together at Jyothis Eye and handing over the podium to you, Dr. Nikhil.
Good evening. Good evening all. I am Dr. Nikhil K, consultant retinal surgeon in Jyothis Eye. I am today evening I am going to talk about complications of diabetes mellitus in mainly the ocular complications. Little bit introduction world. We all know there is a worldwide increase in prevalence of diabetes. We are in a pandemic of diabetes mellitus. From 1980, the 108 million, it increased up to 422 million in 2014. It is rising more rapidly in low income and middle income countries. This is a chart of prevalence of diabetes mellitus, which is mapped in 2000, and it shows a world over prevalence of diabetes mellitus. We all know the types, like type 1, in which pancreatic beta cell failure causes insufficient insulin. Type 2, there is a state of insulin resistance, and gestational diabetes, where insulin resistance occur during pregnancy. The public health burden of diabetes mellitus is from the microvascular and macrovascular complications, which increases morbidity and mortality. Heart diseases, stroke, kidney. The macrovascular complications includes atherosclerosis, and the micro mainly includes nephropathy and retinopathy. The ocular complications mainly include diabetic retinopathy, diabetic papillopathy, the glaucoma, cataract, and ocular surface diseases like dry eye syndrome and diabetic keratopathy, of which I am going to talk here about diabetic retinopathy mainly. Diabetic retinopathy is a microangiopathy of retinal arterioles, capillaries, and venules. It is characterized by retinal vascular permeability, ocular hemorrhages, lipid exudates, and development of new vessels and over retina and posterior vitreous surface. The disease severity scale of diabetic retinopathy and diabetic macular edema classified diabetic retinopathy into mild non-proliferative diabetic retinopathy, moderate non-proliferative diabetic retinopathy, and severe non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. And mild NPDR we classify if we see only microaneurysms in the retina, in the fundus photograph, or in clinical examination, or in the fundus fluorescein angiography. And moderate, we classify it as severe NPDR if there is more than 20 intraretinal hemorrhages in each quadrant of retina, and if there is definitive venous bleeding in 2 or more quadrants, or prominent irma in 1 or more quadrants. We'll classify if it is moderate NPDR, if it is more than mild NPDR, and it is less severe than severe NPDR. And proliferative diabetic retinopathy if there is neovascularization in the retina or vitreous or pre-retinal hemorrhage. we can see microaneurysms here. These red dots are microaneurysms, and these fluorescent dots which filled over the retina is microaneurysms, which is shown in fundus fluorescent angiography. These are another findings in diabetic retinopathy, which is pre-retinal hemorrhages. And these microaneurysms will leak over the retina, and which causes diabetic macular edema and lipid exudation over the retina. And this is an optical coherence tomography finding of a patient with the diabetic retinopathy with diabetic macular edema, which causes profound reduction in visual acuity in patients. Video animation.
Planning you go to the entrance useful. Entrance useful.
Okay.
Video.
As we discussed earlier, these are the venous bleeding in diabetic retinopathy, and this one red-free fundus photograph shows a neovascularization, which is pointed by the arrow, and neovascularization of the disc, optic disc, which is more common in global ischemia, which indicates global ischemia of the retina, which is shown in the fundus photograph, fundus fluorescent angiography in the adjacent picture. We evaluate patient with the diabetic retinopathy with fundus fluorescent angiography and optical coherence tomography, that picture I previously shown. And fundus fluorescent angiography will show in a proliferative diabetic retinopathy patients with neovascularization in the retina. This light bulb like lesions are neovascularization, and this area which is more void of fluorescent is called capillary non-perfusion areas, that is ischemic areas. These are ischemic areas in retina, which is called CNP or capillary non-perfusion areas, and these ultimately lead to a fibrotic switch in the vitreous and over the retina, and finally cause fibrovascular proliferation over the neovascular component, and which ultimately lead to fractional retinal detachment and vision loss, or these neovascularization might bleed over the retina and cause profound vision loss. And a study for the prevalence of diabetic retinopathy in India. It is a study from All India Institute of Medical Sciences, which showed that the prevalence among DR patients is in 16.9, and sight-threatening diabetic retinopathy is 3.6%. And when we have to screen in type 1, we know we have to screen after 5 years of diagnosis, and we have to check the patient annually. And in type 2, at the time of diagnosis, we have to screen, because we don't know when the type 2 diabetes mellitus actually started. But type 1, we all know that we present with acute symptoms, and the complications the diabetic retinopathy develops on prolonged hyperglycemic events, we all know. And in pregnancy, the follow-up regimens are more stricter, because we know pregnancy is a more diabetogenic states, because insulin is countered by more other diabetogenic hormones in pregnancy. Then into the management, first and foremost is the diabetic control. The control of diabetes mellitus and treatment of diabetic retinopathy is mainly from two studies, like diabetic control and complication trial in type 1 diabetes mellitus, and the UKPDS study in type 2 diabetes mellitus, which shown that if we achieve a HbA1c level less than 7%, we can prevent the complications from diabetes mellitus. And Accord study and its follow-up study Accordion showed that if more stricter HbA1c level, like less than 6%, slowed the diabetic retinopathy progression in type 2 diabetes mellitus patients. But such intensive control of diabetic mellitus is not recommended, because it increased the mortality rate. And if we control diabetes over a decade or 2-decade time, this body has a metabolic memory, because when we followed up the patients who had a tighter control in these two studies, they had, even if their control is lost over these next decades, they have the protection for diabetic retinopathy and nephropathy also, which is then we manage diabetic macular edema with intravitreal injections like anti-VEGF injections, bevacizumab, ranibizumab, aflibercept, and intravitreal steroids like triamcinolone, and ozurdex like dexamethasone implant. And we rarely use lasers like focal laser and modified grid lasers. And in management of proliferative diabetic retinopathy, we use retinal photocoagulation, like pan-retinal photocoagulation. We'll destroy the peripheral retina with which reduces the ischemic load over the central vision requiring retina, that is macula, which is paired here, which is shown in the second picture, which is paired here with the. And in advanced PDR, we'll go for a surgical management. We may make 3 ports in the eye, and we'll go and with the vitrectomy cutter, and we'll do the. I'll show you the video. This is the vitrectomy console we use, and these are the vitrectomy probes we used to cut the vitreous and remove the membranes. And so short video. First, initially we make 3 ports to enter into the eye. Okay, we enter into eye with the 3 port like laparoscopy port as general surgeons do, and we with the light pipe and cutter we enter into the eye and remove the blood over there, and then we'll cut all the vitreous and we'll remove the vitreous hemorrhage. We remove the vitreous hemorrhage or pre-retinal hemorrhage through these cutters, and then finally we remove the retinal membranes. And then we do the endolasers with the endolaser probe, and we'll close the eye, remove the ports and close it with either silicone oil inside the eye as a tamponade or gas, C3F8 gas. That's all. Any questions?
Thank you, Dr. Nikhil, for the excellent and the informative talk on the eye in diabetes mellitus, on the topic of
There is a very simple talk for the because statistics initially and source of the prevalence as of year 2000. 2000. We have registered previous data. Science as well as the awareness of diabetes developed. But still, I feel the data, the awareness has not reached your 10% of but at this stage, there is not to be done because the awareness that the 40% of even though we are getting reference from the physicians once in a while, not on a regular basis. So to create awareness among the doctor population, that is the need because doctors go to many doctors and there is the physicians or other specialty doctors. If they traditionally need to come to ophthalmologist and if a ordinary ophthalmologist sees there is no use, it has to reach the right hands with the retinal specialist, that is a medical retinal specialist, to properly diagnose. So after all these hurdles, I think a very small set of units, feelings, in the real ophthalmologist. Something has to be done seriously. Otherwise, this will not be. Now, think that we are detecting more and more cases. Probably that's why it is giving that more than being done. So thank you very much.
Formally, a lot of decisions will carry a servers of people. But nobody is like who will be with the unnecessary it is difficult to afford their authorities. We cannot depend on the so that is the this will formally carry something away. What happened to decisions for the last 2 decades? We have not seen any decision carrying. This is very important information. So that question is there. But now the only thing is you can contact a diabetic and you examine all the diabetic patients. That's the only way. How many cases routinely when you examine you was finding because you use the output. So you use the numbers. Nobody is there, nobody else is fine. Listen, you have to examine the numbers. You not take it.
I have been attending several hospitals across Kerala. No doctor has examined me distance. I was asked respiratory distress while I was in ICU. And I called the nurse and having discovered this false component examining. He was conveniently seeing in the computer. He never touched me. Then I gave it writing. I want me to be seen by a pulmonologist or at least where I am educated. So he came. Then I was on his blog. So writing. Although there was like this thing. So he gave writing and I said, I showed you this. So he got the message. Something from the stethoscope in the world. Where happened every call. Some even to the staff that we gave for my satisfaction. This is the experience in the most leading hospital of Kerala. So forget about the stethoscope from the stethoscope, of course. You need to allow physician again the rejection. But the rule of the thumb is that every more than 5 years old diabetes, he must have a retinal checkup directed for us examination by a medical retinal specialist. Then only it works. You will have a level of ophthalmology. You can depend on me for diabetic retinopathy. I know. So you go to a medical retinal specialist where they are available. Then only your job is done. So that is it.
ये सर्जरी के अंदर मिसलमारी But we are seeing some patient with a small period of diabetes. So, is a relationship between these retinopathy with the threshold or
the diabetic retinopathy will depend upon the glycemic content. The patient diabetic is very drastically
control this. Patients have diabetes of 30 years. Does not happen anything. For some patients with 2 years or 3 years of controlled diabetes, they are producing retinol. Do you think any relationship?
Immediately control the persistent hypertension. And this is what very important for us. There must be some stage to show that we don't see medical people. So control doesn't mean that it's control proper. There are persistent hypertension these are all
Yes. I experienced this. There are some genes associated with the retinopathy. So those patients with the genetic component are getting retinopathy more chance getting I'm having the details of that, what three genes are genetic, and those persons with these genes develop retinopathy faster, others
you can share
scan negative
We express our sincere thanks to Dr. Nikhil K for his excellent and informative talk on high diabetes. Thank you, Dr. Nikhil. Also, we thank all members of Kannur for attending this evening. Thank you.
Please stand for national